Welcome to the first learning block in what we hope will be a 6-block series of education focused on inpatient pediatric nursing. My name is Nikki Johnson, and I'm a global health nurse from Boston Children's Hospital. I've been a nurse for 28 years, focusing primarily on emergency nursing and more recently, pediatric inpatient care. This didactic session will include an opportunity to participate in a pediatric simulation lab scenario, managing neurological events in the context of this case study. As always, thank you for allowing us to partner with you to bring more nursing education to JFK. Our learning objectives for today will be to recognize early and advanced signs of TB meningitis in children under 5 years of age, identifying clinical features of moderate acute malnutrition, also known as MAM, and explaining its impact on infection severity and outcomes. We'll prioritize rapid nursing assessment and interventions for ill-appearing children, pediatric seizures to include airway protection and oxygenation, and this may include administering diazepam and initiating ventilation with a bag valve mask, something we'll probably focus a little more on in our simulation session, and then integrating neurologic and nutritional care into ongoing assessments and management of TB meningitis in the inpatient pediatric ward. So I'd like to introduce you to our friend Kofi. Kofi is a 3-year-old little boy who weighs 10.2 kilograms, has a MUAC measurement of 12.2 centimeters. If you don't know what that is yet, don't worry, we will discuss it more in depth in a few slides. He resides in peri-urban Monrovia, and his caregiver is his grandmother. In terms of his immunization history, it's incomplete, but he does not have a BCG scar, and his HIV status is unknown at this point. Kofi presents to the emergency department at JFK with 7 days of fever, progressive lethargy, poor feeding, vomiting, and 2 days of increasing irritability. He had 1 generalized tonic-clonic seizure at home, lasting less than 2 minutes. In terms of the history of his present illness, his grandmother shares that his fever started 7 days prior to his arrival. It's been intermittent, and for the past few days it has not been responding to paracetamol. Kofi has become progressively less playful and stopped eating solid foods. Vomiting began 3 days prior to arrival, and his grandmother reports a chronic cough for more than 3 weeks and recent weight gain. No known TB treatment in the household, but a neighbor recently died after a prolonged illness with a cough. Those of you who have participated in our August in-service may recognize this pediatric assessment triangle, which assesses a child's appearance, their work of breathing, and the circulation to their skin. So no fancy tools, as we like to say. And we want to decide whether Kofi is sick, sicker, or sickest. So this is the information you currently have. Kofi is ill-appearing, even lethargic. He's responding only to painful stimuli. So when considering the AVPU assessment, alert, verbal, painful, or unresponsive, Kofi is a P for pain. His respiratory rate is 42 with shallow respirations, and his capillary refill is 4 seconds. His conjunctiva are pale. So based on that information, is Kofi sick, sicker, or sickest? Keeping in mind he has abnormalities in all 3 triangles. How would you prioritize his care? Would he be an emergency, or is this someone who can wait to be seen? So if you said sickest, you would be correct. Kofi needs to be prioritized for immediate care. And if we're thinking about which nursing interventions to start with, we should be thinking A for airway, B for breathing, C for circulation, and D for disability or our neuro-eval. So when we consider airway, how do we assess Kofi's airway? Well, we want to get him on a stretcher with his shoulders up, maybe putting a towel or a blanket underneath his shoulders, which will lift his head up and back, hopefully opening his airway. You're going to want to look in his mouth and listen. Is there any gurgling or stridor or any other noises you hear that are abnormal? Does he need to be suctioned? Once you've determined that his airway is open and clear, you want to move on to breathing. Is Kofi breathing? Well, Kofi has a respiratory rate that's 42 and shallow. So we know for a 3-year-old, that's too fast. And shallow means his work of breathing is somewhat inefficient, perhaps. Then we look at Kofi and he looks a little gray. At this point, do you really need to know more, or are you going to want to intervene? Is this a child for whom you'd want to give some oxygen with just this information? And I would say yes, probably. But if you really want more info, I can tell you that his O2 sat is 91% on room air. And you go ahead and you provide some oxygen. And there's no absolute right or wrong way to do this. If you'd like to start with a nasal cannula, go ahead and do that. But know that you did something and you're going to have to assess if it's effective or not. So if his oxygen rate isn't improving, if his respiratory rate and work of breathing isn't improving, if his color isn't improving, then you're going to want to escalate your care to perhaps a simple mask or a non-rebreather. If you chose to start with a non-rebreather, that would be okay too. Just know that at some point you may want to titrate down that oxygen. So we went ahead and we gave Kofi some oxygen. So if we're feeling good, we've reevaluated him, it looks like his respiratory rate has come down a bit, his respiratory effort is a little more effective, he's less gray appearing, we can go ahead and move on to C. And C is for circulation. So we know that his temperature is 38.9 degrees Celsius, which means that Kofi has a fever because anything above 38 degrees is considered febrile. His heart rate is 148 beats per minute, which is fast for a 3-year-old, and his blood pressure is 74/43. So how do we calculate to know what the normal blood pressure is for a 3-year-old? Well, the median blood pressure, or the average blood pressure for a 3-year-old, you would determine by taking his age times 2, which would be 6, and adding that to 90. So the median blood pressure for a 3-year-old is 96. It can be a little lower than that and still be safe. So the lowest we would consider is maybe in the 5th percentile. To do that, we're still doing age times 2, which would be 6, but we're adding it to 70. So the lowest acceptable systolic blood pressure for a 3-year-old is really 76. So 74 is definitely on the low side, but we're not just going to consider blood pressure, right? We're going to look at his capillary refill, which we already know is 4 and prolonged because a normal cap refill is 2 seconds or less. And we know that his heart rate is high. It's 148. Other things we'd want to check for when thinking about circulation, we'd want to check pulses. Are his radial pulses strong and easily palpated or felt? How about his pedal pulses? Can you find those and palpate those easily? If not, that would be a concerning finding that you'd want to describe and document. So if his radial pulses are difficult to find, but you can find them, perhaps you would document +1, which is a quick way of documenting weak. They're relatively easy to find, maybe a +2. So things you definitely want to document in your nursing assessment. Now, given that information, I think we want to intervene at this point because these numbers are concerning. Heart rate's too high, blood pressure's too low, he has a fever, his cap refill's prolonged, so we want to establish an IV. So right now we're going to pause and we're going to go ahead and we're going to start a 22 gauge IV in Kofi's right hand. And are we going to want to give him a fluid bolus? Yes, we put an IV in for a reason, but I would caution you that we know that Kofi's MUAC score was a little on the low side. I'm telling you that now. We'll explore that in more depth later, suggesting that there might be a malnutrition problem or an undernourishment problem with Kofi. So in the case of children with moderate to severe malnutrition, we're going to bolus fluid differently than we would for a child who has a normal, healthy weight. We're going to give less fluid and we're going to give it slower because children with malnutrition are at a higher risk for congestive heart failure. And if you give them too much fluid too quickly, they will become fluid overloaded. So in Kofi's case, we're going to go ahead, instead of giving 20 mils per kilo, we're going to give 10 mils per kilo, and we're going to give it over a minimum of 30 minutes and perhaps even over an hour. And we'll talk about that a little more a little later on. But we did something, and we know that anytime we do something, we have to reassess our patient. So after you gave Kofi that 10 ml per kilo bolus, his cap refills now 3 seconds, which is somewhat improved. His heart rate is now 125, which is very much improved. And his blood pressure is now 94/62, which is almost the median for a 3-year-old. So initially, I think at this point, actually, we can probably move on from circulation, if you agree, and go ahead and think about disability or a neuro exam. So initially, Kofi was only responding to painful stimuli when pressure was applied to his nail bed. That's how we check painful stimuli in kids. And what we'd want to see is that eye-opening response when a bit of pressure was applied to his thumb. And per ETAT guidelines, if a child is unresponsive or their exam is concerning enough, you don't have to do a glucose check to save time. You should just assume this child needs some glucose. So his glucose check was initially 3.1. We had the sticks available, so we went ahead and did it, but you don't have to. So 3.1 is equivalent to 50.4 milligrams per deciliter. So that's on the low side. And we're going to treat that with some IV dextrose. And we know when we treat hypoglycemia in children, we give 5 mils per kilo of 10% dextrose. So we're going to look at Kofi's weight, we're going to do that math, and we're going to go ahead and we're going to give that dextrose solution. And once the glucose is infused, the patient responds by opening his eyes when his grandmother says his name. So now he has a V. He's responding appropriately to verbal stimuli. Do you feel like Kofi is now stable? Yeah, I think so too. So now what? Let's pause for just a minute and talk about tuberculosis globally and then as it affects Liberia. In 2003, there were 10.8 million new cases of tuberculosis globally. This is still a critical health issue. In fact, tuberculosis remains the #1 infectious disease killer worldwide, surpassing even HIV and AIDS. The number of deaths from tuberculosis was approximately 1.25 million. This data is from 2023, the World Health Organization, and that death rate really demonstrates the severity of this problem. Tuberculosis is both preventable and treatable, but the high global numbers show that efforts to control and eliminate it still face significant challenges. Nurses worldwide, including here in Liberia, play a key role in preventing the spread of TB, administering medications, and ensuring proper follow-up. In Liberia, TB is still a significant burden. Liberia is classified among the top 30 nations worldwide with the highest tuberculosis burden. The incident rate of 308 cases per 100,000 people is notably high, which means that tuberculosis is widespread in Liberia and poses a major challenge in our healthcare system. In 2023, Liberia recorded 7,447 tuberculosis cases. While this number is concerning, it's also an indication that the country's health system is identifying and diagnosing TB cases more effectively. Nurses should be particularly alert to TB symptoms in children, as the disease can often go unnoticed until it becomes severe, especially in vulnerable populations like those who are malnourished or who have weak immune systems. One critical aspect of tuberculosis care in Liberia is the high rate of TB and HIV co-infection. All TB patients are tested for HIV. And in 2003, about 10% of those with TB were co-infected with HIV. It's important to note that about 90% of these co-infected patients were started on antiretroviral therapy, or ART. ART is essential in managing HIV and improving the response to TB treatment, as it strengthens the immune system and reduces the likelihood of drug resistance. For nurses, understanding the interaction between TB and HIV and monitoring for potential drug interactions is vital in ensuring the best outcomes for our patients. How do kids get tuberculosis? Well, it's caused by a mycobacterium called tuberculosis. It's a slow-growing bacteria that spreads in tiny airborne droplets when someone with active TB coughs or sneezes. And the size of that TB mycobacterium is really important because the smaller the droplet, the lighter it is, and the longer it can hang in the air, making it highly contagious. So if you walk through an area that someone with TB, with active TB, coughed in, spraying those aerosolized droplets all over the place, the longer they hang in the air, the more likely you are to breathe in those droplets. Children mainly get infected from adults in the household with active pulmonary TB, or TB that's active in their lungs, especially when they're living in crowded or poorly ventilated conditions. The symptoms of TB are a little bit tricky because they mimic so many other childhood illnesses that unless you get a really good long-term history, you might mistake it for something else. But children, especially those under 5 years of age, develop TB faster and more severely than older children and adults, including TB that affects the brain, which is sometimes TB meningitis. Childhood TB is often misdiagnosed, and it can be ascribed to pneumonia or meningitis because the symptoms are very similar without the context of the longer health history of the child. TB can produce disease in nearly every organ. It's treated with antibiotics over many months, and if TB is in the brain, bone, or multiple sites, treatment can often take up to 12 months or longer. So different symptoms you might see with TB: fevers, cough, night sweats, headache, confusion, enlarged lymph nodes, belly pain, joint pain, poor weight gain or even weight loss. You see these in a lot of different things, so sometimes it's difficult to diagnose TB definitively in a child. TB meningitis usually develops within months or even weeks after primary TB infections, most commonly 2 to 12 weeks after infection. But in young children or children under 5, it can occur as early as 2 to 4 weeks. Why does this happen in young children? After a child inhales that Mycobacterium tuberculosis, the bacteria establish infection in the lungs, often with few or no symptoms. From there, TB can spread through the bloodstream. It's also called hematogenous spread. Then small TB lesions, or lesions called rich foci, which you can see in the scan on the right, seed the brain or the meninges. When those little foci, those little circles you see rupture, TB meningitis can develop because when those little foci rupture, it can spread into the CSF. Young children are at higher risk because they have immature immune systems and there's poor containment of the TB infection. There's a higher likelihood of disseminated tuberculosis, which could include TB meningitis or miliary TB. Let's quickly review again what happens when those tuberculosis brain foci burst. So when those TB lesions rupture in the brain, they leak into the cerebrospinal fluid, and that causes severe inflammation in the brain, thick exudate around the brain, and swelling and blockage of that cerebrospinal fluid flow in the brain and throughout the circulatory, the neurovascular system. How does that affect the brain? It causes an increase in intracranial pressure. It reduces the blood flow to the brain. It can cause possible hydrocephalus, and it can cause brain and nerve damage. So pretty serious things. What are the nursing red flags if you suspect TB meningitis? Things you need to act immediately on. So if your child has a fever for greater than 5 days with lethargy and irritability, that would be concerning. Kofi has had that. He's had a fever for 7 days with lethargy. Poor feeding or vomiting without clear cause. Kofi has that. Altered consciousness or decreased responsiveness. If you'll recall, Kofi's AVPU was a P. He was only responding to painful stimuli when he presented, so that's certainly altered consciousness. Seizures, new or recurrent. Kofi had a full tonic-clonic seizure lasting less than 2 minutes at home. So check. Neck stiffness or bulging fontanelle. We're not sure if Kofi has this yet because we haven't done a secondary survey. Malnutrition, as represented by a MUAC or mid-upper arm circumference score of 12.5 centimeters or less, which Kofi does have. So if that doesn't make sense to you yet, don't worry. We'll again discuss it in more depth shortly. And then known or possible TB exposure. If you'll recall, Kofi's neighbor recently died after a prolonged illness with a cough. So given the rates of tuberculosis in Liberia, it may well have been tuberculosis, and Kofi may have been exposed to it. None of these red flag signs are truly unique to TB though, or TB meningitis, which makes it a little challenging to diagnose. TB is often diagnosed by its pattern, its progression, and its risk context rather than just a single sign or symptom. Given the challenges around diagnosing TB meningitis, how do you know it's TB meningitis? Well, you can look at a symptom comparison and include that history. So symptoms that are often seen with TB meningitis but aren't necessarily unique to TB meningitis include seizures and stiff neck and bulging fontanelle and vomiting and altered consciousness and maybe even respiratory distress, which often occurs after a seizure or after medication for a seizure is given. But what makes TB meningitis different? If you need to look at the TB pattern, the illness is often slow in onset. So instead of hours, it takes days and weeks to develop. There's usually early systemic signs, so poor feeding and weight loss. Neurologic signs appear a little later in the disease progression, but seizures in particular indicate that the disease is quite advanced. So we can compare TB meningitis to other illnesses that are often misdiagnosed. So TB meningitis is sometimes misdiagnosed as bacterial meningitis, but bacterial meningitis, the onset is very sudden with really severe onset of symptoms. With cerebral malaria, there's often an acute onset of fever with coma. And then with TB meningitis, it's gradual and there's very often malnutrition associated with it. So TB meningitis is defined more by how symptoms develop and not necessarily which symptoms appear. But it can often again, be misdiagnosed as bacterial meningitis, cerebral malaria, viral encephalitis, hypoglycemia, and even severe sepsis. Let's go back to Kofi's case and ask 2 key questions. What symptoms fit TB meningitis, and what in his history makes TB more likely than other causes of meningitis? Symptoms that are consistent with TB meningitis that he has: 7 days of fever. This is important because TB meningitis typically presents with a prolonged subacute fever, not sudden in onset like bacterial meningitis. Progressive lethargy and irritability. TB meningitis often causes a gradual change in mental status over days to weeks. This slow progression is a key clue. Poor feeding. It's a very common early sign in young children with TB meningitis and often precedes obvious neurologic findings. Vomiting. This suggests increased intracranial pressure, which is common in TB meningitis as inflammation builds slowly. Seizures. Seizures are not unique to TB, but in TB meningitis, they usually occur later in the disease, indicating more advanced brain involvement. None of these symptoms alone are diagnostic, but together they form a classic TB meningitis pattern. What are the historical features that point toward TB symptoms that have developed gradually over a week? TB meningitis progresses over days to weeks, unlike cerebral malaria or bacterial meningitis, which often worsen rapidly over hours to 1 to 2 days. Chronic cough for more than 3 weeks. This raises concern for pulmonary TB, even if not formally diagnosed. Recent weight loss. Weight loss supports chronic infection and systemic illness consistent with TB. Community exposure. A neighbor who died after prolonged illness with cough suggests possible TB exposure, which is highly relevant in high burden settings. No response to paracetamol. Persistent fever despite symptomatic treatment suggests a serious underlying infection. TB meningitis is not identified by one special symptom. It's identified by the pattern, prolonged fever, and gradual neurologic decline, plus those TB risk factors. By the time a child with TB meningitis has a seizure, the disease is usually advanced. This is why early nursing recognition matters. I want to take some time to talk about why it's important to consider malnutrition in any child you think has TB, and quite frankly, any child that's ill, because malnutrition is going to have a negative impact on their recovery. This is a lot of information. I'm really only trying to give you a brief overview. We don't have time to dive too deeply into this, but there are some resources on the last slide of this presentation from the World Health Organization that are up to date within the past few years that really focus on undernutrition and tuberculosis, as well as malnutrition and chronic illness. So if you want to know more, those are 2 really good resources that definitely apply to your work environment. So moderate acute malnutrition. Why do we care about it for COFI? Because it reduces cell-mediated immunity. And having a strong immune system is critical to controlling TB. So now that he has malnutrition and TB, that really is a double whammy, 2 things working against him. So we absolutely, as his healthcare providers, have to pay attention to both. Children with moderate acute malnutrition are more likely to have more severe TB disease. They're more likely to deteriorate to severe acute malnutrition even while they're in the hospital. And they're more likely to develop secondary infections such as sepsis or pneumonia. A child with TB meningitis and moderate acute malnutrition is at a much higher risk of death than a well-nourished child. TB meningitis causes poor appetite, vomiting, difficulty swallowing, altered consciousness, increased metabolic demands, in part because of those fevers. This means a child with moderate acute malnutrition can rapidly worsen to severe acute malnutrition during admission while in the hospital if nutrition is not actively managed. Many TB and supportive medications also depend on nutritional status. So malnourished children have altered drug absorption. They have a higher risk of toxicity, in particular from meds they need to take to treat their TB, such as isoniazid. They have an increased risk of hypoglycemia. Nurses play a key role in monitoring weight in that MUAC or mid-upper arm circumference while a child is in your care. You need to observe your patient for feeding tolerance and report vomiting, poor intake, and lethargy. Children with moderate acute malnutrition are more vulnerable to hypoglycemia, especially during illness or misfeeds, and electrolyte disturbances. These complications can mimic neurological worsening and be mistaken for progression of TB meningitis. Recognizing moderate acute malnutrition helps nurses differentiate nutrition-related deterioration from neurologic disease. TB meningitis already causes brain inflammation, increased intracranial pressure, risk of long-term disability, and adequate nutrition is essential for brain repair, neurodevelopment, and preventing long-term cognitive impairment in children. Children with untreated moderate acute malnutrition are more likely to have poor neurodevelopmental outcomes even if they survive. Children with moderate acute malnutrition and TB meningitis may need more frequent, smaller feeds. They may need assisted feeding, where a 3-year-old may have previously been able to feed himself. Kofi may now need someone to help him feed. Careful monitoring to prevent aspiration, early referral to nutritional services if they're available, and nurses are often the first to notice weight loss, reduced intake, and feeding difficulties in their pediatric patients. Moderate acute malnutrition is a window for prevention because early nutrition support can stop deterioration. It prevents a need for F75 and F100 later. It shortens hospitalizations and improves survival. Now that we understand why we need to pay attention to nutrition, let's look at Kofi's nutrition history. Kofi has had a poor appetite for several weeks, which is common in chronic TB infections. He stopped breastfeeding early, removing an important source of calories and immune protection. His diet consists mainly of rice water and occasional cassava, which are low in protein, fat, and micronutrients. His grandmother reports recent weight loss, suggesting chronic undernutrition, not an acute problem. This tells us Kofi was already nutritionally vulnerable before becoming acutely ill. Let's look at Kofi's mid-upper arm circumference score. It's 12.2. Using our bands, which we're going to pause and do some hands-on learning with in a moment, moderate acute malnutrition is classified with a MUAC band as 11.5 to 12.4 centimeters in the mid-upper arm. He has visible wasting of his upper arms. He has no bilateral pitting edema. Again, we'll talk about that more in a minute. And his weight for height Z-score is approximately -2 to -3. We'll also go into this a little more, but a Z-score requires both a weight and a height, and a normal score would be 0. Anything less indicates that the patient is underweight compared to his peers. Anything more indicates the patient is overweight compared to his peers. So what is moderate acute malnutrition? That means Kofi is undernourished, but not yet severely malnourished. But given he now has a chronic illness that has landed him in the hospital, he is now at high risk for becoming severely malnourished. A simple definition of MUAC, 11.5 to 12.5 centimeters for moderate acute malnutrition. Let's compare the Z-score with the MUAC score. Again, MUAC, mid-upper arm circumference. The Z-score tells us how far from normal a child is. Remember, 0, normal. Less than 0, underweight. More than 0, overweight. In a sick child, the mid-upper arm circumference is often the fastest and most reliable way to assess malnutrition. MUAC tells us what the child has left, muscle and fat, not how much fluid they are carrying. Weight is often a measurement of fluid as well, and if a child's really ill, they can become fluid overloaded, which can skew your perception of malnutrition. So why weight can be misleading in sick children? Weight can change quickly due to factors that are not nutrition related, such as IV fluids, fluid overload, and edema, ascites, and rehydration or dehydration can all affect weight, but not necessarily muscle mass. A child may appear heavier because of fluid, even though they have lost muscle and fat. Fluid weight is not nutrition. So in the case of your hospitalized sick child, a daily MUAC score may be a more reliable indicator of their nutrition status than a weight alone. I'm not saying not to weigh your child. That's actually really important when you're trying to figure out if they're fluid overloaded or not. But maybe do both of these things to get a really good picture of both nutrition and fluid status. We're going to pause momentarily to pass out the MUAC bands and practice measuring mid-upper arm circumference. But first, let's look at how to quickly assess for severe acute malnutrition versus moderate acute malnutrition. This is really important in emergency situations when you need to fluid resuscitate a child, because a child with severe acute malnutrition is at a much higher risk of congestive heart failure. And if you bolus them quickly with 20 mils per kilo of Ringer's lactate or normal saline, they'll quite likely become fluid overloaded. So we want to avoid that. And there is a quick way to assess for severe acute malnutrition. You're going to take your thumbs and press them down on the tops of your patient's feet, both of the feet, for 3 seconds. So 1, 1,000, 2, 1,000, 3, 1,000, let go. If you can see the indentation of your thumbs clearly in both feet, that is a sign, a fairly reliable one, of severe acute malnutrition. And for that child, you're going to fluid resuscitate if your assessment warrants it and your provider is ordering it, but you're going to do it at perhaps 10 mils per kilo rather than 20, and you're going to do it slowly. And you're going to be reassessing for signs of fluid overload. So you'll see puffiness develop around their eyes, and their hands, and their feet, and their wrists, their ankles. You may see tightness develop around their abdomen as they retain fluid. That's called ascites. You want to listen to their lung fields bilaterally to hear if they're developing crackles. Again, a sign of fluid overload. Is their respiratory rate increasing? Are they becoming more short of breath? Those would all be indicators of fluid overload in a severely acutely malnourished child who's receiving fluid. So important to do that quick assessment in an emergency situation, and frankly in general if you feel your child needs IV fluids. But let's talk about MUAC, or the mid-upper arm circumference. So this measures the tissues most affected by acute malnutrition. Acute malnutrition causes a rapid loss of muscle and subcutaneous fat, and that mid-upper arm circumference is taken at the mid-upper arm in an area that has little bone mass relative to muscle and fat. It shrinks quickly when a child becomes malnourished. Because MUAC reflects body tissue wasting, it is a strong indicator of acute malnutrition. MUAC strongly predicts the risk of death. Numerous studies have shown MUAC is better than weight for height, or that Z-score we talked about, at predicting mortality in young children. Lower MUAC values are directly associated with a higher risk of infection and a higher risk of death. This makes the mid-upper arm circumference clinically meaningful and not just a measurement. MUAC is minimally affected by dehydration or edema, but weight-based measurements can be distorted by dehydration, fluid overload, and edema, which is common in malnutrition. MUAC remains relatively stable despite fluid shifts. This is critical in sick children where weight can be misleading. MUAC is age independent within 6 months to 59 months or 5 years. So any child between 6 months old and 5 years old can be accurately measured for malnutrition with a MUAC band. MUAC changes very little with age between 6 months and 5 years. This allows the use of fixed cutoffs. So 11.5 centimeters or less indicates severe acute malnutrition, which you'll see on the MUAC band below in red. And then 11.5 to 12.4 centimeters indicates moderate acute malnutrition, which you'll see in the yellow area on the band below. There's no age calculation or growth charts that are needed for a MUAC measurement, which makes it very handy and very quick. I want to point out that Kofi does not have severe acute malnutrition based on his MUAC measurement, but I do think it's important to talk about refeeding syndrome in children who may have severe acute malnutrition, because it's not uncommon for hospitalized children to lose weight, particularly ill children. So Kofi could become, at some point in his hospitalization, severely malnourished. Or you could be caring for children that are severely malnourished. So knowing about refeeding syndrome is important. Refeeding syndrome is a metabolic complication caused by rapid reintroduction of nutrition in severely malnourished children. And this can lead to dangerous electrolyte shifts, cardiac and neurologic complications to include cardiac arrest. And nurses prevent it by slow, frequent feeding, close monitoring, and correct therapeutic diets. Refeeding syndrome is a dangerous metabolic condition that occurs when nutrition is started too quickly, again, in a severely malnourished child, so kids whose MUAC scores are in the red on that band, or kids whose MUAC scores are in the yellow but also have that pitting edema on their feet. Refeeding syndrome happens because the child's body has adapted to starvation, and sudden feeding causes rapid shifts in fluids and electrolytes that the body just cannot handle. In severe malnutrition, the body's stores of phosphate, potassium, and magnesium are very low. The heart muscle becomes weak, and metabolism has slowed to conserve energy. When feeding is restarted too quickly, insulin releases increase and electrolytes move rapidly from the blood into the cells. And this causes blood levels of those electrolytes to fall dangerously low. Children with TB meningitis already have brain inflammation, altered consciousness, an increased seizure risk, and an increased metabolic stress. So refeeding syndrome in these kids that are also severely acutely malnourished can worsen confusion and reduce consciousness. It can increase seizure activity. Cardiac rhythm problems can occur, to include sudden deterioration and even sudden death. These signs can be mistaken for worsening TB meningitis, which can delay the correct treatment. To take a slightly deeper dive into refeeding syndrome, low phosphate levels can lead to weak heart contractions, respiratory muscle failure, and reduced brain energy supply. Low potassium or hypokalemia can cause abnormal heart rhythms, muscle weakness, and paralytic ileus, so a slowing or a stopping of things moving through the GI tract. And then low magnesium or hypomagnesia can cause seizures, cardiac arrhythmias, and increased neuromuscular irritability. So definitely a pattern here, right? Really important to pay attention to this. So how do you avoid refeeding syndrome? Look at that middle column under safe feeding. You're going to start feeding slowly and cautiously. The type of feed should be therapeutic, preferably with low protein initially. So if you have F75 or F100, you are not going to start with F100. You will start with F75. Feeding frequency should be small amounts of food and fed frequently every 2 to 3 hours. Electrolytes need to be balanced with minerals, with a specific mineral mix included. Blood glucose really needs to be stable, so you may be checking that more frequently. Heart function needs to be monitored. You need to to routinely check blood pressure and heart rate and cap refill, and listen to those lung sounds to see and hear how effectively that heart's beating. Check those peripheral pulses. Neurologic status, you're going to want to do neuro checks routinely depending on how sick your kid is, but at least every 4 hours you want to check their pupils. Are they symmetrical? Are they round? Are they reactive? What's their behavior? Are they responding quickly? Are they spontaneously opening their eyes? What's their baseline neurostatus, and have they deviated from that in any way? So on this slide, you can see a locally prepared recipe for F75, which remember has lower protein than F100. So F75 is on the left of the slide, and F100 is on the right of the slide. I think it's really important to note the CMB, or mineral electrolyte mix, which is part of both of these formulas. It matters. This mix, often called CMB, provides potassium, magnesium, zinc, copper, selenium, iodine, other electrolytes, which are all crucial for safe refeeding of children with severe acute malnutrition. Without it, kids can suffer dangerous complications like refeeding syndrome, heart issues, or worsening edema. Standard sugar, milk, and oil alone is not a safe substitute. You really need that CMB mix, and you can get more information on it and how to obtain it from the World Health Organization. Again, if you have a kiddo with the severe acute malnutrition, when you start to feed them again, you're going to want to use the F75, not F100. You want the lower protein recipe. Kofi, let's go back to Kofi. Kofi has been admitted to the inpatient pediatric ward from the emergency ward. He's been on the pediatric inpatient unit for about 6 hours when you, as his bedside nurse, notice that Kofi develops a generalized tonic-clonic seizure that lasts for more than 5 minutes. So start thinking about what you need to do as his bedside nurse to keep him safe during this seizure. And I'm assuming there's more than one person working in the ward, so what can you delegate to the people around you? Does Kofi have an IV? Is it flushing well? Is there someone designated that could potentially drop diazepam if this seizure doesn't stop? Who's assessing his airway and his breathing and his circulation? So you notice, while Kofi is having this seizure, that he becomes cyanotic. His lips get blue, his nail beds get blue, his skin becomes a little dusky. What is it that you need to do right now? Do you need to give oxygen, or is oxygen enough? You also notice that he has irregular shallow breathing. Do you need to know anything else to know that you might have to do some bag valve mask ventilation just to get Kofi through this seizure activity? Probably not. This information should be enough to know, okay, I have to breathe for him for a little bit just to get him through this seizure. But you have help, and a team member was able to obtain an O2 sat, and that O2 sat is 85%. So your priorities right now, ABC. I'm going to make sure his airway is open and protected. Part of that means putting him into the recovery position, which we'll look at in a few slides. But if you need to breathe for him, you need to position his airway such that you can bag, get a good seal and bag. Help him breathe through this seizure. Someone else needs to make sure that IV's patent and hopefully has that diazepam drawn up and ready to go. There's a provider at the bedside that can help direct care and really give orders. When a child has advanced TB meningitis and starts to have seizures, they can become somewhat common due to that brain inflammation. So there's increased intracranial pressure and reduced blood flow to the brain, which results in more seizure activity. A seizure in an admitted child is a medical emergency that requires rapid, organized nursing action. Nursing priorities during a seizure, as we've already said, but they're really important and worth repeating. Maintain that airway. Protect the child from injury. Stop the seizure per protocol and order. I think your first drug is typically diazepam. Someone needs to observe and document what's happening in the patient record and call for help early. The nurse's first responsibility to the patient is safety and airway protection. It's so important not to panic, to follow a systematic approach, ABC, and early action prevents brain injury and death. So if you see that seizure activity, ABC, think airway, breathing, circulation, really protect that airway in particular. If you have to ventilate a seizing patient with a bag valve mask, the recovery position isn't clearly the best position to bag. But if you don't have to bag the patient, if their respiratory effort is adequate, their skin color is good, and you don't need to support their airway in such a position to bag, the ideal position during a seizure is this recovery position because it allows the mouth, should they have vomitus or anything, it allows the airway to stay clear. You put a hand under their head, particularly if they're lying on the ground or a hard surface, just to help support their head. And bending their knees keeps their body from rolling. So this ensures the airway is open, suction secretions if needed. You can administer oxygen, difficult to bag, but you can administer oxygen from this position and monitor breathing closely. With Kofi, he was cyanotic and had ineffective respiration, so just giving him oxygen is not going to be enough intervention. You really needed to bag him through this seizure. Keeping in mind that hypoxia worsens brain injury and oxygen support is critical during and after seizures, especially in children with TB meningitis, but keep an eye on that respiratory effort because you may have to actually give them supportive respirations, not just oxygen. So we use typically, and at JFK, I believe, diazepam to stop seizures. So if a child is actively seizing, the medication you want to give, ideally through a patent IV, is diazepam. And your diazepam is available in these little glass ampules that have 10 milligrams and 2 mils, which is the equivalent of 5 milligrams per ml. It's the most common first-line medication for acute seizures, and it's used because it rapidly stops an active seizure. It's widely available and familiar to staff, great for emergencies. Ideally, you're giving it IV, but we'll talk about how to give it rectally as well. So for an IV dose, it's 0.2 to 0.3 milligrams per kilogram. That is going to be a decision made by your provider, who's hopefully at the bedside. If you'll recall, Kofi weighs 10.2 kilograms. So go ahead and do that math for me. Kofi is 10.2 kilograms, and you're going to give a dose of 0.2 milligrams per kilo. So figure out how many milligrams you're going to give, and then let me know how many mils that's going to be. Keeping in mind the maximum single dose of diazepam is usually 10 milligrams. You want to give it a slow IV push, so over 2 minutes, which is hard to do in an emergency high-stress situation, but that's when it's great to have a friend who can help time it. And very important to monitor airway, breathing, and oxygen. Have oxygen and suction available because diazepam can make children drowsy, and you just want to make sure it doesn't suppress their respiratory drive. So I know this sounds obvious, so I'm going to say it anyway, but for pediatric seizures, diazepam is always given by weight. So someone should always be doing that math. If your IV for some reason isn't patent, and I would just add this is why it's so important to flush your IV at least every 8 hours while you're caring for a patient to make sure if an emergency should happen, the IV works. But say in this case the IV is not flushing, you can draw your diazepam up into a tuberculin syringe, those little 1 ml syringes with the syringe removed. Drop the dose. It's going to be higher than IV dosing. It'll be 0.5 milligrams per kilogram. So again, Kofi's 10.2 kilograms. How much diazepam are you going to have to give to Kofi if you're giving it rectally? So 10.2 times 0.5, and then figure out how many mils that is. To administer this, you're going to insert the tuberculin syringe with the needle removed into the rectum, inject the diazepam into the rectum, and hold the syringe there for about a minute before you remove it, just to make sure the medication remains in the rectum. And again, always important to watch that respiratory effort to make sure it's not depressed. Diazepam stops seizures. Phenobarbital prevents seizures, and I do believe this is the most common medication you have to prevent seizure activity at JFK. It's most commonly used maintenance anticonvulsant in children. It's effective, it's inexpensive, it's widely available in Liberia. It's used for neonates, infants, children with CNS infections, to include TB meningitis. It can be given IV and it can be given orally. Nursing points to consider: it can cause sedation and drowsiness. Important to monitor respiratory rate and level of consciousness if you're giving this medication to your pediatric patient. You want to ensure the correct dosing. Again, all pediatric drugs are weight-based, including this one. So do the math, make sure it's correct, whatever the order is. And phenobarbital has a long half-life, which means it hangs around in the system for a long time. In kids, that can be as long as 110 hours or nearly 5 days. So really important that doses aren't mixed. That long half-life also means that you have to give it less often. So you may only be giving it once a day because it's going to last for a very long time. We've spoken about these emergency nursing interventions a few times, but I think they're very important and worth repeating. So again, for your seizing patient, a child can become post-ictal after a seizure, which means they can be drowsy even after the seizure is stopped, and they need to be closely assessed to ensure an adequate respiratory effort. You may even need to support that open airway with a jaw thrust or their head tilt chin lift. Be prepared to suction their airway if they're too drowsy to clear their secretions on their own. And oxygen via face mask may be needed, but again, they have to have effective respirations if you're going to give them oxygen. Oxygen alone, when a child is not breathing effectively, is not ideal. Bag valve mask ventilation may be required due to that decreased respiratory rate and effort, poor chest rise, or low oxygen saturation. Oxygen alone may not be enough to fix a low oxygen saturation. You may need to breathe for them for a period of time as well. And then think about your circulation, or that C in your ABC. IV fluids need to be carefully managed, not just because our patient is undernourished, but also because that TB meningitis could raise that intracranial pressure, and adding more fluid could also increase intracranial pressure. So always give IV fluids very carefully, meaning whenever you do something, you have to assess your patient to make sure they're tolerating your intervention safely. Some new information here, but also some review. Your ongoing nursing management of your patient with TB meningitis. You may not know immediately that this is TB meningitis. Their symptoms and their history may make you highly suspicious, but we've likely sent off some testing to the local lab to confirm that's what this is. Until those test results come back, you'll be giving IV antibiotics until bacterial meningitis is excluded. When the TB test comes back positive, you'll also be initiating that anti-TB therapy based on your national protocols. You may be giving corticosteroids to help decrease that inflammation that's occurring in their brain. you're going to be monitoring them for seizures. Kofi has already had 2 seizures now, so there is a very good chance that he may have another. So really important that you're monitoring and watching for that seizure activity so that you can intervene as quickly as possible. And then again, nutritional rehabilitation has to be part of his care. It can't be an afterthought. It has to be an active part of his care plan, because if he loses more weight, his risk for a bad outcome, to include death, increases. So close monitoring for raised intracranial pressure, recurrent seizures, aspiration, also hypoglycemia. Just if he loses that mentation, if his mental status changes, you can't assume it's not hypoglycemia. So these patients are very complicated. They're busy. There's a lot of tasks involved, and your brain's constantly working to go, okay, what could this be right now? Tough case. So knowing the work environment that you're in, as simple as some of these things sound, I know they can be very challenging, in fact. So ongoing inpatient nursing care, a simple thing that can decrease intracranial pressure is ensuring that the child's head is raised at least 30 degrees. That sounds simple, but if the heads of your bed don't go up and down and you don't have pillows available, raising that child's head's actually a bit challenging. So hopefully the family has some blankets or some clothes they can put under the child's upper torso and head to raise them, or maybe mom, dad, or one of the caregivers can have the child kind of reclined against their grown-up body to keep their head elevated. You want to avoid excessive noise and stimulation, also super challenging in the work environment that you're in, but whenever you can, do whatever you can to minimize noise and stimulation for these kiddos, because it's just going to increase their agitation and make them more uncomfortable. So you want to observe for worsening headaches, repeated vomiting, reduced consciousness. All of these things can indicate worsening TB meningitis, worsening nutrition status, hypoglycemia. There's just so many things that could be going wrong that you just have to watch for really closely. Nursing care, nutrition and support. You want to encourage small, frequent meals. Again, challenging, but this is when you have those conversations with the caregiver and talk about a plan and a time frame for how much and how frequently this child needs to eat. Support breastfeeding if possible. Monitor weight and hydration, but also monitor your MUAC score, not just weight. Remember how we talked about the MUAC is really a better measurement of malnutrition than weight alone. And then preventing aspiration in drowsy kids, always having your suction available, make sure it works. Have them in their recovery position with their head up as much as possible if their level of consciousness is kind of waxing and waning. Big picture things in terms of your ongoing inpatient nursing care, you're going to be monitoring that temperature, vital signs, and level of consciousness, not only monitoring but documenting it at least every 4 hours. More often, if you're concerned about your patient's stability or any acute changes in their status, you're going to need to do these things more frequently. But minimally every 4 hours, you're going to get vital signs and to assess their level of consciousness and to do a general neuro check. Are they moving their arms and legs? And are they moving their arms and legs equally on both sides? Are they able to push against resistance equally on both sides? If you're checking their pupils, are their pupils equal round? Sometimes difficult to check for reactivity with a light in kids because they're not always cooperative, but you can passively observe them and at least look to make sure their pupils are equal and round and that they're tracking and following your voice appropriately. Is their speech clear? Are they making sense? All of these things are simple but really important neurologic evaluations that you can do as their bedside nurse. Obviously, you're going to observe for ongoing seizure activity, and really important to assess feeding and hydration. Documenting their input and output is so key, and measuring their weight every day to make sure they're not fluid overloaded. In infants, you can check their fontanelle. Is it depressed? Is it bulging? Is it flat? And nursing care with medication support. Really important for TB in particular that families understand that strict adherence to the anti-TB drug protocol is key to recovery and to avoid developing antibiotic resistance. And then corticosteroids potentially to reduce brain swelling. So really making sure that a schedule is maintained. Watching for side effects such as vomiting, jaundice, and rash of some of those medications. So really important to do some really thorough teaching with the family, because hopefully this little friend Kofi is going to go home with his grandma, and you want to make sure grandma really understands the medication plan and the follow-up plan. Well, that's it. That's our whirlwind review of TB, meningitis, and pediatrics, and a friend that also has moderate acute malnutrition. Really did not deep dive into any of this, but I hope you learned enough to stimulate your curiosity so that you'll want to learn more, and share with your colleagues too, particularly when they're new to your unit. There's a lot of basic information here that applies to more than just this patient with TB meningitis, and it can apply to many of the other patients in the population you care for too. Some great open source references that are available for free on the internet, all from the World Health Organization. So you should be able to click right on these links and get to these resources fairly readily. And hoping that we'll all be able to reinforce some of this learning in the simulation lab. And as always, it's always such a pleasure to be here. You guys are amazing hosts. And I really, really enjoy my visits to Monrovia. So thank you.